Greetings, everyone. Thank you so much for joining us today for our Policy Power Lunch, today, November 2nd, 2022. My name is Kyle Shavasta. I am the project coordinator here at the Policy Impact Project, and I am happy to be joined by my co-host today, Anne Rue, who is the co-director of the Policy Impact Project here at the A.J. Drexel Autism Institute. And also joining us is our newest member, Sam Voltaire, who will be live tweeting today's event. You can join them over at impact_policy over on Twitter. So a little bit about the Policy Impact Project. We're a joint venture of the Policy and Analytics Center under the direction of Dr. Lindsay Shea and the Life Course Outcomes Research Program. Our goals are to bridge the gaps between research and policy, shortening those gaps and shortening the time between research actually gets to policy and research can influence policy. We focus a lot on translating research, so it's accessible to everyone, policymakers, activists, advocates, and lay people. And we do this with a focus of hopefully creating better policy that influences and addresses the expressed needs of autistic people and their families. You can find out a little bit more about what we do, like I mentioned, over at impact_policy on Twitter. And you can visit us at policyimpactproject.org. So before I hand it over to Anne, just want to go over some brief house rules. To ask the panelists questions, please put them in the Q&A box below. And please frame it in a question just so it's easy to translate from Q&A box to question. We will facilitate those at the end. If you are experiencing any technical difficulties, use the chat box. It is set up where your needs will go directly to the hosts. If you are interested in closed caption, you can just hit the little CC box below that is enabled. And with the speaker's consent, today we are recording today's presentation and it will be archived on our website. Also, this is important. We love feedback. At the end of today's presentation, there is a survey. It's going to pop up. Please take it. Please let us know how we're doing. We want to hear from you. Also, just a quick note on language. Language is ever evolving. Language is not the endpoint of addressing inclusion, but it's a great start in drawing that circle wider. So during this webinar, we're going to make an attempt to decenter traditional gendered language. This topic is one that impacts many identities and different intersections. So we want to be as respectful and understanding as possible. And with that, I would like to hand it over to Anne.
Thanks, Kyle. Welcome again, everyone. Just a couple of standard disclaimers. Our opinions expressed today by our speakers do not necessarily represent the views of the Policy Impact Project, although we are very interested in this topic today. Our academic institution receives federal funding, and as such, we are a politically neutral entity, so we are not here to endorse any specific issues, bills, or candidates. But with that said, we strongly encourage you to vote as it is connected to our topics today. Next slide. So we're obviously here today as a result of the June 24th Dobbs decision, which overturned Planned Parenthood versus Casey and gave back the power to the states to regulate abortion. This decision was condemned by the World Health Organization and by many professional bodies. You can see in the map here that the darker states represent states where abortion is now illegal. This map is updated daily because this is an ever-changing and evolving situation that impacts on many rights beyond abortion, and that's what we're here to unpack today. But this is really a public health imperative, a public health issue, because lack of access to abortion, replicated research shows, has many implications for people's health and well-being at the family level, in addition to the person who has actually experienced lack of access to abortion. So this equates to a failure to provide comprehensive care. And this is a very complex topic with many layers, and my colleague Sam is going to show us a visual to help frame our conversation today.
All right, so one model for defining and explaining and talking about sexuality, it's really helpful and illustrates the overlapping segments that influence sexuality, is called the circles of sexuality. And it was created by Dr. Dennis M. Daly. So within that, we see that in the middle, there's power and agency, and then several circles overlapping around it. So the first one is sensuality, which talks about awareness and feelings within one's own body and other people's bodies. Sensuality typically enables us to feel good about how our bodies look and feel and what they can do. Then there's the circle entitled intimacy. So that's the ability and need to be close to another human being and accept closeness in return. So aspects of intimacy can overlap with sensuality, such as sharing, caring, emotional risk-taking, and vulnerability. Then we have the sexual orientation and gender identity circle. So this is more about how a person's feelings, sense, or understanding of who they are when it comes to their gender. Basically, their feeling of being a man, a woman, neither, both, or a different total way of expressing gender altogether, and the ways they express those feelings. It also involves who, which can be based on or not at all related to gender, they feel sexually attracted to, whether they seek out or have the opportunity to be in a sexual relationship, and who they choose not to be in relationship with. And of course, sexual orientation, which is our sense of being queer or straight, and that there are several different labels that can fall into that, such as homosexual, heterosexual, bisexual, asexual, pansexual, etc. Then what we'll be talking about here today as it relates to sexual health and reproduction. So one's capacity or ability or lack thereof to reproduce, feelings about and experiences with reproduction, and the behaviors and attitudes that play a part, not only in sexual health, but sexual enjoyment as well. This includes information we have about sexual anatomy, sexual activities, reproduction, contraception, STI prevention, and self-care. So basically sex education, among other messages and information that we're given about all of these things. And then closing that out is sexual behaviors and practices, which put simply is who does what with which body parts, items, and or partners. And back to that center with power and agency. So power within is derived from a sense of self-worth and understanding of one's preferences and values, which enables a person to realize sexual well-being and health. Power to influence is another aspect. So power to influence, consent, and or decline sexual activity. Power with others to negotiate and decide. And power over others. So this is when people use sexual acts or sexuality to manipulate, control, or harm others. So looking at a larger circle, Kyle, if you could click the next. Yep. So we have two rings. We have social and interpersonal factors and sociopolitical and cultural factors. So sociopolitical and cultural factors influence everything, particularly how and if we're able to express and or act on these various facets of the circles of sexuality. And interpersonal relationships influence our own understanding, conceptualizing, and of the circles. So as we go throughout the presentation today, keep this in mind as we go through the discussion and as our panelists continue to share their thoughts with us. So that's jumping right in. So I'm going to introduce our three panelists today. So Dina Gassner is an appointed member of the Interagency Autism Coordinating Committee, also known as the IACC, providing recommendations to the Office of the White House regarding autism research funding. She's the co-chair of the Autistic Researcher Committee, ARC for short, for the International Society for Autism Research, also called INSAR. She's also a member of the Autism Intervention Research Network in Physical Health, and is a member of the ARP Gender, Sexuality, and Healthcare Node. As an autistic woman, she seeks to live a life of authenticity. Morgan Hunter, pronouns they, them, is an autistic social worker whose work focuses on making systems change to address violence against the disability community. Much of their work focuses on raising awareness of the ways in which systematic oppression contributes to the loss of autonomy of disabled people and people with disabilities, particularly individuals who experience multiple forms of oppression. Oluwatobi Odegunwa, they, them, is an autistic and chronically ill advocate for disability and racial justice and LGBTQ rights. Their academic experience is in intersectionality and health justice, as well as gender and sexuality. Oluwatobi is the program coordinator at the Autistic People of Color Fund and is involved with local social justice organizations. They currently work as DEI consultant at a publishing company. And without further ado, our panelists. And Kyle, you can take it away.
Thanks, Sam. We're going to start off today with unpacking some basic terminology to get us all on the same page. And I want to acknowledge first that in talking about reproductive health, that is a movement that was initiated by white women of privilege and likely did not take into consideration marginalized populations, including Black and Brown people, people with disabilities who may have different experiences firsthand about needs around reproductive health. So that has been recentered as more of reproductive justice, which encompasses many different types of injustices and isms. And I'm going to turn it over to Oluwatobi. I'm going to ask you to help us understand a little bit more about what reproductive health means versus reproductive justice and how it intersects with disability rights and disability justice.
Thanks, Anne. So reproductive health or reproductive rights has, like you were explaining, has more of an individualistic framework and was started by white women. And it has a focus on like the legal system and is also very much focused on access to contraception and access to abortion. On the other end, reproductive rights, reproductive justice is an intersectional framework that aims to give everyone the ability to do 5 things: control their own body, choose to have children, choose not to have children, choose how you'll have those children, and take care of your children in a healthy and safe community. And reproductive justice was started by Black women. And so disability rights and disability justice kind of like fall under like those same lines. So disability rights is about like making life better for disabled people under our legal system. While disability justice focuses on advancing the lives of disabled people by highlighting and like uplifting the most marginalized in our community. So it's very much like reproductive justice, intangible from intersectionality. And for anyone who is interested in DJ, disability justice, I recommend looking into the 10 principles, some of which are anti-capitalism, interdependence, sustainability, and like cross-movement solidarity. So DJ includes reproductive justice, and reproductive justice also includes disability justice. So they're both dependent on intersectionality, and like they demand that you recognize all parts of a person and not just their gender or like their disability. So every disabled person has a gender or is non-binary and has a race, a sexuality, a body size, as does everybody who can like have children and parent those children. So at their core, reproductive justice and disability justice are about like imagining and like working to build a world that makes it possible for everyone to have a happy and fulfilling life. They're about like tearing down systems that kind of reduce people into producers of labor, and like force people into like hierarchies dependent on, different identities. So at their core, they're really about making sure that everybody has complete control over their body, and making sure that like they live in a world that like doesn't interfere with that control.
Okay, thank you. That is really helpful. We hear a lot these days in the media about reproductive health, reproductive rights, reproductive justice, but we often don't hear about the intersection of disability. And so, Morgan, could you help us to understand a little bit more about, over time, how disability rights and justice, reproductive rights and justice have changed? Because the Dobbs decision didn't really come out of nowhere.
Yeah, so one of the things that I think is really important, particularly in the country that we're in, I'm not sure if anyone is joining us internationally or not, but the United States has a really long history of eugenics policies. And by eugenics, I mean kind of like the government kind of like taking a role in deciding who should and who should not be having children. The word eugenics itself literally means kind of like good genes. So there's this idea that some people have good genes and some people don't have good genes. And so, and as Oluwatoyibi was saying, intersectionality is really important in thinking about who is impacted by eugenics as well, because was not just targeting disabled people, it's also BIPOC folks, sex workers, and anyone who is kind of in the criminal injustice system, among others. And so even though we don't use the word eugenics anymore, since it fell out of favor with the Nazis, it still really impacts a lot of the ways in which we think about sexuality and disability. Particularly when you kind of consider like the history of institutions, and that one of the primary purposes of institutionalizing disabled folks was to essentially keep them out of environments where it might be easier for them to find a sexual partner to be able to have children. And so part of that is preventing them from having kids, as well as, of course, actually forced sterilization that is still legal. And so one of the things that shows up, even though like we might not be institutionalizing people as much anymore, and in some places like you can't, it's harder to sterilize people forcibly. I mean, you still can, but it's harder in some places. But even then, one of the things that is still very much present is in a lot of the sexual health curricula that is particularly which is made for disabled people, really has a strong focus on prevention, as opposed to looking at all of the circles of sexuality, and that instead it's really focused on like preventing harm, particularly through like preventing people from getting pregnant or preventing like STI transmission. So it's really kind of like focused on controlling people's bodies. And oftentimes there's this sort of assumption when you look at a lot of like research that disabled people are either having too much sex or too little sex, or the way that they're having sex is oftentimes portrayed as just sort of weird. A lot of use of terms like paraphilia or hypersexuality to describe the sexuality of disabled people. And so there's just a lot of pathologization of disabled people's sexuality, and a lot of the attention on disabled sexuality is on trying to control or prevent it or trying to normalize it in some way. And so I think that's really important to kind of keep in mind.
Yeah, there were so many positives that were starting to happen with the disability rights movement in particular. And I think there's been this subtle erosion of disability rights and reproductive rights over time that has led to the Dobbs decision. And some of these things we talk about today might sound outlandish to people, but the unfortunate reality is so many negatives have occurred in history, such as history of sterilization and things that are real and are potentially things that could resurface again. We'll talk about that more in depth later. But Dina, all of these changes also have effects on sexuality. So could you help us understand a little bit more about reproductive health versus sexuality, what the interplay is there?
Well, I think I want to focus more on the commonalities rather than the differences. In both categories of information, they include the right to health, right? Autonomy, body control, freedom from paternalistic protection mentalities, but allow people to think about intimacy and however their sexuality is experienced as a positive, sex positive way. You know, we don't see much of that when it comes to disability discussions around intimacy and the expression of sexual interests. I think that we underestimate how much education disabled people can benefit from when we talk about teaching individuals about intimacy and sexuality and gender. A lot of information is withheld under presumptions that it doesn't apply. And that puts people at great risk, but it also, again, pulls from their autonomy. I think they should have the right to non-stigmatized reproductive health care free of discrimination, however your disability is expressed. In regard to my community specifically, some of us share this community in terms of autism. You know, we are highly influenced by unique challenges associated with autism. So things like sensory issues are very important for doctors to understand. Interoception and body disconnection issues, whether it's an aspect of your autism or whether it's a manifestation of prior trauma, is really important to connect with and helping people to get back in their bodies so they can communicate about themselves. Understanding traumatic events in terms of big T, we all know about the big T's, but little t traumas that autistic people experiences, whether it's not asking your gender identity when you walk into a reproductive healthcare center, or the constant assault of sensory input, or the communication breakdown because people aren't being clear. All of those little t traumas have a cumulative effect. We need to remember that sexuality and reproductive healthcare includes not just physical access to reproductive healthcare, but also the mental, emotional, and social well-being associated with one's gender identity and sexuality. Both should include the right to see sexuality and intimacy through individual experiences, right? Again, emphasizing positive experiences related to sexuality. Both are informed by our experiences, our self-image, and our own unique personalities. And unfortunately, with the threat of the Dobbs decision, freedom around decision-making for both sexual expression and reproductive health care are an immediate and extreme risk.
Thanks for connecting those like you did, Dina. That was really helpful. I think that these healthy experiences of sex, of access to care, of reproductive health, of acknowledgement of how one identifies their gender, all of these things can be impacted by economic stability, employment. There's so many issues that come into play on whether people have these healthy experiences. Morgan, can you help us understand a little bit more about the connection of how poverty is more likely in people with developmental disabilities and how that influences?
Yeah, so if you look at any of the research, the overlap of poverty and disability, it's quite clear that disabled folks, I mean, are oftentimes kept in poverty, and part of this relates not just to like people having barriers getting employment, of course, but also accessing a lot of things like Medicaid that have income restrictions. And so a lot of folks are essentially kept in poverty in order to access the care that they need that, you know, would be, otherwise they might not have access to insurance otherwise. And so, so for a lot of reasons, disabled folks are oftentimes like poorer than the rest of the population. Another big issue that can come up is like the cost of medical care, that someone might not look poor on paper, but because of like all of their medical expenses, they actually are. And so that can be another issue just because of how expensive care might be. And then of course, when you're thinking about reproductive justice issues, we know that like one of like the main reasons why people choose to have an abortion is financial reasons, of course. And so when you're thinking about a population that's already struggling financially, that having like children that they can't afford to take care of, that's going to impact them more, and particularly if they already have children, but then that's going to impact those children as well. And so it kind of just creating like deeper and deeper poverty, and potentially like putting people in this situation of like choosing between of course, like providing for their children or accessing medical care that they need as a disabled person. And so, and then that's not even getting into all the issues of just people having kind of like more complex health needs that are going to come up around pregnancy and disability. But yeah.
Can I add, we need to remember how many women are pushed out of the workforce because of the inadequacies of special education services for their children. Many women have to pull out because the school is constantly calling them to pick up, or their child isn't safe in that environment. So that has implications for disabled and non-disabled women in the workforce. Sorry to jump in, but that just popped up, sorry.
There are so many vulnerabilities that people with disabilities face, and then all added types of challenges that autistic people face. And it feels like just all of everything associated with having rights taken away just deepens and deepens those complexities, like you said, Morgan. In regard to there have been a lot of historical injustices against obviously people who are Black and brown, but also people with disabilities. And Oluwatobi, I think you wanted to share some about the Autistic People of Color Fund and how reparations are possibly assisting communities.
Yes. So I work with the Autistic People of Color Fund, and what we are is a mutual aid fund that gives microgrants to autistic people of color. So we give money up to $500, and that money, like unlike other, there's less hoops in an organization to kind of jump through, and it's really like direct assistance. So if you're autistic and a person of color and you're listening to this, or you know someone who is, like, please apply. We have both a general application and an emergency application, which is like right at a quicker rate. So yes, that's we're one of the few direct funds, but yeah.
Okay, thank you, because reparations are so important for fostering community solutions. Thank you. Kyle, I'm going to turn it over to you to talk about some of the myths around these topics.
Absolutely. And thank you everyone for making those connections between the Dobbs decision and disability rights. A lot of the times when we talk about these issues, things can be opaque or vague. So really solidifying that connection is helpful. What I want to do right now is talk about some of the more hazier topics that are overlooked when discussing the Dobbs decision. So right out the gate, this is open to everyone. What are your thoughts? What do you want? We have an active audience right now, and thank you everyone for staying with us. What do you want people to know watching about sexuality, reproductive health, and the disability community, specifically autistic people? What do you want to tell the audience?
It can be fun.
I think one thing I'd like to dispel is that, like, autism isn't inherently an illness. It is like an identity, it's a neurotype, and like I think under the medical model, autism and autistic people are kind of defined by how inconvenient we make life for non-autistic people. And I think that when you look at people who grew up in understanding homes, safe homes, healthy homes, like they don't present the way some other autistic people do. So I think it's very important to recognize the impact of trauma on how, like, we view autism and autistic people.
Morgan?
Yeah, and that reminds me also, I'm in the position of, like, my partner and I are planning to have a baby in the near future. And as an autistic person, one of the things that I'm really looking forward to is the potentiality of having autistic children, since I'm fortunate enough to have had like an autistic primary caregiver, and well, neither of us knew we were autistic back, then when I was a kid. I can think back to like so many moments where feeling this kind of like shared bond with like my mother, because of this like shared neurotype, and the like realizing like this is kind of like something that's been in my family for generations. She likely had like siblings that were probably autistic based on kind of like family anecdote, and probably her grandmother was. And so like one of the things that I'm really looking forward to, like rather than seeing this as like, oh, like because in some framework you could say, oh, like my children would be at risk for being autistic. And it's like, yes, I'm hoping that they're autistic. Like this is something that's been in my family and something that like I want to like cherish, and like the act of kind of like raising an autistic person to like support them is something I really look forward to. So.
And can I piggyback on that, Morgan? You know, I'm an autistic mother. I raised an autistic son. My daughter is also neurodiverse with ADHD and anxiety. Her son has sensory processing issues and anxiety. And I get to watch her parent him through the lens of a neurodiverse framework, right? Honey, do you need to go outside to get the wiggles out? Look at my nose instead of look at me, you know? Just little nuggets that I know she observed in our household that's making her a more sensitive parent to this little guy who's just too badass for me.
Awesome. Thank you, everyone. Yeah, and that actually leads me to think about you know, people oftentimes, I am an autistic self-advocate myself, and people oftentimes apply an infantilization lens or asexuality to us. And in fact, I remember having a conversation with a partner about consent, and they were like, can you consent? And I'm like, of course I can. Like, come on. Like, come on. So thank you for bringing up all these really salient and important points around sex and autism. One myth, I think that leads us to our first myth to talk about, is that autistic people don't have sex and can't or don't need access to birth control or protection, and they're not affected by, you know, changes in reproductive health care. What are your thoughts around that?
Someone actually asked me that in a foreign country. Do autistic people have sex? And I'm like, I have 2 kids. Immaculate conception? Then she said, no, I mean men. Do autistic men have children? Like, of course they do. You know, there's a lot out there. It's kind of like astonishing to me.
I think my specific experience with that myth kind of like resulted in like an over-sexualization of myself, because I think it, so I'm autistic, and I also use a cane and wheelchair. And when I started using my wheelchair, that like the need to show that I was a sexual being kind of like, it like got heightened just because of how people saw me, like the difference between how I was treated while walking with a cane versus like being in my wheelchair, was like, and that it hadn't like led me into like unsafe situations, but it definitely led to like uncomfortable encounters, and just like kind of discomfort like within myself and around like people who I should have been comfortable around. So I think like, yeah, I think that's something that a lot of people also experience.
Awesome.
You make me want to mention this. As a young girl, I experienced sexual abuse at the hands of a step-parent. And what he reinforced for me is that sexualized behavior is how you get attention, because he never gave me any attention unless I behaved in these ways. And that followed me all the way through my undergraduate status in college. And it's kind of funny, my classmates now still identify me as a very sexualized person, when in fact I was really not nearly as busy as they thought I was. But it was because of this externalizing behavior that I had adopted to be included in that environment. And of course, it made me extremely vulnerable and led to ensuing victimization. I also think it was part of the behavior that led to me being victimized in the church. I think that predators can just see this history of grooming in our past as it manifests through our personalities, especially when we're adopting masking behaviors to try to blend in. And we may not be able to delineate what is sexualized versus what is just the way people behave. So I just want to add that illustration.
Thank you for sharing that, Dina. And yeah, I think that goes along with the perception that there are heightened vulnerabilities for autistic people, but that leads a lot of folks to think that they just need to be protected and they are not able to be advocates or, you know, have autonomy or have a sense of themselves within themselves. So yeah, thank you. Any other thoughts before we move on to the next myth?
I know in a previous conversation, Dina, you mentioned, I'm forgetting what the term is, something about risk, like the right to take risk, basically.
Yeah, I'm sorry, go ahead, Morgan.
Was it dignity of risk?
Yeah.
Yes, it was you, Morgan, yes.
Right, and I do believe in that. I do believe that people should have the dignity to take risks that other people take. I think where I was not adequately supported is I've got no training, no information about boundaries, about limitations. And I think it's because my mother was also on the spectrum and she was also victimized, pregnant at 17, you know, and I just never got any direct instruction. I've heard other people say my mom was a nurse and she told me way too much, way too soon, you know. So, I mean, I think it's up to the family to really know their person, give them as much information as they can handle at different times developmentally, and just sort of gradually feed them the information. I do think we tend to wait too long, though, to talk about protective issues and personal space and boundaries around that. I think 3- and 4-year-olds can learn about where people can touch them and where they can't and who's allowed. So.
Thank you, Morgan.
Yeah, speaking of that, I'm working on a literature review right now. One of the things that I've been noticing that folks are talking about a lot and in regards to sexual health education is just, yes, that that parents oftentimes, I think, perceive that they're like autistic young person is not ready to talk about these things until kind of like fairly like late in life. And so I know, like thinking back to my own self, like as a young person, I think my parents perceived that I was much less interested in sex and like not sexually active like when I was, even though I was in my 20s, because it was an environment where you were not allowed to express that you had any interest, and so you just learned to pretend that you didn't. And so then it's like, well, of course they're not interested, so we don't, so this is not an issue. And I think that's also just like realizing that autistic people are also most sensitive to, you know, social like expectations around if you're told sex is bad, this is not for you. You're going to learn that you have to kind of, you know, make it seem like that's what you are, you know, are believing, even if it's not true, and even if you actually do need support.
We've talked too in our prior conversations about how being told things like this is not for you, or what types of information people decide for you that you need can relate to these labels, like that we are trying to get rid of, high functioning and low functioning. What are your thoughts on that? I know you have a lot to say on this.
So looking at the medical model, when we use high and low functioning, somebody always gets left out, and it's elitist, it's classist, it de-emphasizes someone's strengths and overemphasizes someone else's, and it assigns the challenges of disability onto the individual. When we use terminology like low and high support needs and add a qualifier, high support needs requiring 24/7 support, where we're assigning the breakdown is to the systems of support and not onto the individual. And so I find that to be very relevant to me and our family. I am the individual in my family who's presumed to have no limitations. And when my autism reveals itself, when my rain barrel's too empty and I can't produce, it's usually assigned character judgment, right? But I have a son who's absolutely brilliant that have expressive language issues. And much like people who have strokes are presumed to have an intellectual impairment, even though it doesn't happen, they have a motor problem. My son is treated very comparably. And so I just think that we need to look at individuals that way, as individuals with a scattered array of strengths and challenges. And we need to spend much more time focusing on the strengths than the challenges when it comes to supports and services, maximizing benefits, maximizing opportunities within the framework of that individual's specific cognition.
And Morgan?
Oh, Oluwa Toby, I know you had also unmuted. Did you want to speak?
Oh, you're good to go ahead.
Okay. Yeah, I think, yeah, I think that the more like I have learned about this, I think I know that sometimes people even like using like terms kind of like support needs. I think it's really like higher low support needs. I think it's really important even then to make sure that we're not just like using that as kind of like shorthand for kind of like higher low functioning, and trying to like not just like group people into two categories, because that doesn't really work that way. And I think and one of the things that does, of course, is that it makes it really hard for people to get supports if they're somehow like their scoring just kind of like ends up in this way that it looks like they need less support than they do, just because of the way that these things are characterized. And it's really, really frustrating that way. But yeah, I think one of the things that I've read is that like autistic people tend to, I think Dina mentioned this, but autistic people tend to have like a lot of like disparities and kind of like strengths and kind of like support needs. And so it should not be surprising that someone might be able to be really good at doing this one thing or a couple of things, but then also need a lot of support in other areas. Like that should not be surprising at all. That's kind of the norm from kind of like what I've seen. And so trying to just categorize people into two like buckets like that is not really helpful, I think.
That's why we need the qualifiers, right? And I'm also starting to sense in the community what I'm calling, for lack of better terminology, hidden shames, right? So because I'm so high functioning, I can't admit to anyone that I have a sink full of dirty dishes right now, and that I could really use 10 hours a month of in-home support services that would take me over the top in terms of my personal productivity, right? And people would assign that as asking for a privilege instead of it being a support. And people who have lots of money hire people to do their dishes, and it's not a privilege, and well, it is a privilege, but it's out of choice and out of the freedom to prioritize their efforts. But for us, it's something we're supposed to be ashamed of because we should be able to, right? My son doesn't have any trouble keeping up with his dishes in his way of being. In fact, he tells me to do the dishes if I don't do them quickly enough for his agenda. So I just think it's important to recognize that every autistic individual has something they could use support for, even if it's only 5 or 10 hours a month. It could be a game changer. I also encourage people to go to the IAC playback from last week's meeting. John Robeson gave a personal testimony about his lived experience of aging and living with autism. And I recommend a Chardonnay and a box of tissues, because it just wrecked me, because it's just so authentic and so transparent and fearless. And so if anybody wants to go to look at that, I recommend it very highly.
Thank you, Dina. And yeah, I think that points to a lot of unintended consequences in connecting the Dobbs decision to, the realities of autistic people's lives. People assume a lot. There's a lot of assuming that goes along with, everything we're talking about today. People assume that they can make the decision for autistic people, or they assume they know what their needs are, based on, those labels. So yeah, thank you, everyone.
So categorizing people using false labels like high functioning, low functioning can obscure people's real experiences with health and healthcare. And so we want to get into talking about some of the considerations or unintended consequences from the Dobbs decision that most likely the people who made the decision did not consider, but are everyday realities for autistic people and people with other disabilities. So, Dina, I'm going to go back to you again to share a little bit about medical considerations.
Sure. So I just wanted to bring up one thing right away, is the idea of communication. It's a misnomer to think that people who have the use of spoken language are always able to communicate. When it comes to reproductive health care access, you know, the most articulate individual in any other room may experience a flood of adrenaline, of cortisol, and we know from neurological studies that those chemicals can shut down one's communication capacity. I think we need to remember that reproductive healthcare access also means access for people in poverty. It means access for people with other conditions, including polycystic ovarian syndrome. And I know a lot of autistic individuals who menstruate report that they have great difficulty with the experience of menstruation. So having access to birth control methods that vary and can be individualized is really appropriate. A lot of times, all of these things can be made worse if they don't have access to, say, the birth control pills or an implant or whatever they choose to work with. We today did invite another colleague of ours to participate who identifies as, I'm not ready to talk about sex. And I think that's a really important voice. It isn't that she doesn't experience sexuality or intimacy, but developmentally, she reports she's not ready. But she also reports these benefits, which I think it's important to hear her voice about. The first OBGYN I went to locally didn't understand my needs. I tried to advocate ahead of time, and she was worried that my screaming or crying would disrupt or disturb other patients at her office. Seeing her was like walking on eggshells. It was awful. She would see me and prescribe birth control without doing a physical exam or touching me because she was afraid of her. I found a list of disability-friendly clinics years ago, and one of them is only an hour from me. I got on the list and have been going there ever since. It's been an amazing experience. It takes the right environment, support, and provider. Years ago, I didn't feel well and we didn't know what was wrong, and I'd been hurting for 2 months. And I do remember her saying that she couldn't say how she hurt. That's the interoception breakdown. She would say, I hurt. That's all she could get out is I hurt. And they'd say, where? And she'd go, tummy. And that wasn't really giving the doctors a lot to go on. So they had to do a tremendous number of tests to close the gap between what she was experiencing and what she could communicate. And upon being referred to urology, she was correctly diagnosed with a chronic bladder condition and treated. I'm so glad my OBGYN knew what she did and was able to recognize the condition and refer me. She also reports that birth control is critical for her, and she doesn't think she's the only one who uses it because she finds having menstruation to be so dysregulating for her. She says it has been awful in the past, just too much sensory meltdowns. I use birth control to help with my quality of life and as a tool to make it so that I can live the best life and be regulated. I think that's just everything that I could possibly offer you in terms of why access to reproductive health care and birth control is so important. I'm here identifying as the voice of menopause. I also identify as a cis woman, and I can say from my lived experience, and probably through many people, we are not prepared for anything past puberty, and even puberty is really probably not effectively addressed. But we need to also use the same intentionality as we're preparing women for puberty and individuals for puberty. We also need to prepare them for childbirth, for parenting, for menopause. There's tremendous work being done in the UK by my colleague Christine on menopause. We're just not properly equipped with strategies or tools, and we have no idea what we're supposed to do and what's typical for those experiences.
There are so many points of knowledge that need to be conveyed and so many points of access that need to be gained. And Oluwatobi, it makes me wonder what your thoughts are on people of color and their access to reproductive health and information.
Yeah, that's well, it's definitely there are a lot of racial disparities in healthcare, and I know like some of like the there are some like also some myths regarding people of color. I know one that I'm still shocked. I can't even like imagine how you would think this, but like a lot of people like don't believe that Black people can feel pain. Like a lot of doctors. I know there was like a survey or a study that was done that kind of like revealed that. And when like what that means is that like doctors are less sensitive, so they don't ask you like how you're feeling. And if you're already like disconnected from your body and like or are unable to communicate in like a way that's like that they would understand, like you're already, you know, there's a gap that happens here, and like that results in like, you know, people not receiving medications that they need. It results in higher mortality rates for like Black birthing people and also like their children. I think that like another place where that kind of like intersects is like medical racism and also like medical fat phobia, where like the solution to every fat person's like medical request is, you know, lose some weight, eat, you know, eat right, exercise and like lose weight, and that'll fix everything, which also leads to the same issues where Black people and fat people, disabled people often have conditions that have progressed further than they should have, like they should have been caught earlier, but because doctors don't believe these people are and they're unwilling to like to do certain tests, those issues aren't caught before like they're much worse. I know a lot of like another part where that intersects is like people who are like of color, people who have like substance use disorder, people who have chronic pain are often like whenever we mention that we need pain management, we're often like seen as like seeking opioids, which like sometimes people do need opioids, but I think that like just those like mentalities from doctors kind of make it so that certain people are not as healthy as they should be, and it honestly kind of like goes along with eugenics.
Absolutely. Morgan, do you have anything to add to that?
I don't think so, no.
Okay. I think we've talked also about intersection with sexual violence. And while we touched on that, I wondered if you had anything else to add about risk in that area.
Yes. So yeah, I think as I was mentioned in my introduction, like kind of like my real area of interest is looking at sort of sexual violence, and of course, I think as has been mentioned, autistic people and disabled people generally experience high rates of that, and that's, you know, been confirmed in the research now. And so, yeah, just thinking about as far as people being denied access to reproductive care that they might need, and how that's going to like show up in terms of people experiencing violence. Like one way of thinking about that is like there could be like circumstances where people are getting pregnant by sexual assault and then not able to access an abortion that they might need, or then thinking about like the ramifications for people being trapped in an abusive relationship if their abuser gets them pregnant to trap them there and not having access to the reproductive care that they need. And even just kind of like lack of access to like birth control, and how that can also kind of like play into that. And so I think it's both in terms of like thinking about like people having unwanted pregnancy as a result of sexual assault, but then also how sexual assault can like play into kind of maintaining like dynamics of power and control, and of course also it's like a fairly well-known fact that when people are experiencing domestic violence and are pregnant, that it's usually kind of like the risk of violence is even higher when they are pregnant. And so just kind of thinking about like additional layers of violence kind of playing into that with like forced pregnancy, it is kind of scary.
It is such a huge concern, especially when complicated by issues of lack of autonomy, difficulty with communication, maybe not realizing the extent to which, how you are being controlled and lack of power. So thank you for explaining that. Kyle, I want to turn it back to you so that we can at least touch on some ideas about reproductive health advocacy.
Absolutely, yeah. And thank you everyone for providing, once again, these wonderful points to chew on and to think about as we, go forward in a world where Dobbs overturned Roe v. Wade. So yeah, with that, I think a big question and a big consideration is, how are you all providing care for your community and advocating for your community, and how can people out in the real world outside of Zoom, this is a real world, but we're in Zoom, how can people advocate for themselves and for their community as well? What are some of your thoughts and tips? Morgan?
Yeah, I think one of the things that has really been important for me in like the work that I do is like centering like folks' pleasure and kind of like pleasure and autonomy in like really in everything. Like I think like a place to start from that is thinking about providing sexual health education that really centers people's pleasure. And by pleasure, I don't just mean kind of like sexual pleasure, like having orgasms, but just thinking about like what are the things that make people feel good and affirmed generally, like on like a very broad level. I mean, that of course includes like reproductive justice as far as like, do you want to have children and in what way, and like what can support you to have children, of course, but also just generally like what are the things that are going to help you feel good, and really framing it in terms of that rather than all of the language around kind of like control and restriction that we kind of talked about earlier, which I think a denial of like bodily autonomy is one part of that violence. So that would be kind of like my thought, kind of like a place to start. But
thank you. That's actually really helpful, because sometimes we can sanitize or pathologize our advocacy. So centering pleasure in it is really helpful.
Yeah. I think also like when we're centering pleasure and like sexual education that centers pleasure, also remembering the way that like different people's bodies work, that sometimes the way disabled people have sex is going to be different from how non-disabled people might have sex because of sensory issues, mobility issues. So that's like, yeah, that's a conversation that also like needs to be had.
I'm going to say something a little politically charged, since as a speaker I'm allowed, but I think that we need to recognize Dobbs as a way of controlling not only reproductive health care, but as a way to interfere with the engagement of women in society. We know what life was like for women before there was access to the right to choose reproductive timing or not having the timing to do this. We know what the support for paid leave is for women in the workplace. We know what the limitations are around children in the workplace, and how limited meaningful access to safe spaces for special education services are. We know how inflexible family paid leave is, and other policy changes that even have improved are still weak at best. So I think we need to support anything that allows for women to be actively and meaningfully engaged in society. And we need to dismiss positions that will push more women out of the spaces that we occupy by mandating child rearing. It's a very easy way to pull us out of the dialogue. I did want to mention too, around domestic housing or domestic violence, I read an article that housing safety is one of the #1 reasons women and other people stay in abusive scenarios is mandated poverty. The partner doesn't want them to work. And then if they have a child, the child and them are dependent on that housing option. So any policies we can do to create safe long-term housing for all disabled people, let's just say that, but especially in this situation, I think will help with a lot of this.
I'm also thinking about like healthcare. If like you are a stay-at-home parent and your spouse is the one who is working, and your healthcare is tied to their job, like that's also like a reason that you can't leave a situation. I think like if we're like another thing that needs to improve is as people are unable to access abortions, like more children are going to end up in foster care and going to end up for abortion. And those systems are racist, white supremacist, like they're just all kinds of bad, and they're really like unsafe for children. So I think that like that's another thing that we need to focus on, like improving or honestly getting rid of and starting over.
Tremendous. Thank you. Thank you so much. When we said we were unpacking the topics, I don't think we were lying with that. There is so much interconnected here, and there's so much more to talk about. But I think, you know, in our policy power lunch, we also don't call it a policy power lunch for nothing, because we power through the topics. You all provided such insight and such, once again, salient points, and I hope the audience can go away with some talking points and bring it back to their communities and to their jobs.
And if there are any adjacent topics or things that our audience members are interested in hearing more about, we're happy to further this conversation and continue to expand. So thank you everyone for listening today. So such a warm thanks to our panelists. You all provided just such a breadth of expertise and personal experiences. And, you know, it's not a topic that we could really adequately address without you all being here today. So just thank you. Thank you.
Thank you for having us.
Yes, thank you for having us.
Great working with you folks.
Okay.
Thank you.
Bye, everyone.
Bye-bye.
Bye.
Thank you, everyone.